Good afternoon. From the Department of Nephrology, we are going to present topic which is a type of a glomerular disease which is very common, and in continent it is different than the. If we see the type of patient who present in nephrology OPD at All India Institute, little old slide but covers 15,000 patients, and the star mark on the x-axis is the syndromic presentation of the patient in OPD, and the star mark is those syndrome where the etiology may be glomerular disease. If we combine every such patient, then approximately 30 to 40% of patients in nephrology OPD has got glomerular. If we see the glomerulus, there are three major components. One is cells, there is glomerular basement membrane, and third is mesangial matrix. Broadly, glomerular diseases are clinically classified as proliferative and non-proliferative. Proliferative means if any one of these three major type of cell, mesangial, endothelial, and parietal cells, if any of them proliferate, then usually it's a syndrome of a proliferative nephritis, and if there is abnormality basement then without any proliferation, then it is non-proliferative. Now, this is a survey published in 2018, International Kidney Biopsy Survey covering 42,000 patients. And if you see the confidence glomerular disease of various primary and secondary glomerulonephritis, is IgA nephropathy, is approximately 60%. This covers 4 continents. In the world, then there is a potential burden of disease in terms of IgA nephropathy. Across the world, it varies from 6% to 40%. In Indian continent, which is covered by the subsequent approximately of all although first described in 1968 by Jean Berger in terms of a mesangial-proliferative nephritis with diffuse IgA deposit, still there are major controversy on three broad areas. Also, but I will just highlight the one is the burden of disease. If you see the glomerular diseases on the left side are 5 clinical syndromes with which glomerular disease can present. Acute glomerulonephritis, nephrotic syndrome, rapidly progressive glomerulonephritis, asymptomatic urinary abnormality, and chronic kidney disease. Now, what IgA nephropathy requires is a histological diagnosis, so every patient needs to be biopsied. Not only biopsied, but it should also have a immunofluorescence so that it can demonstrate predominant IgA deposit in the mesangium. But you see the controversy. Now, many acute glomerulonephritis are not biopsied. Many asymptomatic urinary abnormalities are not biopsied, and many chronic kidney disease are not biopsied. So if you don't do biopsy, even though if you biopsy, unless we do immunofluorescence, we cannot label a patient of IgA nephropathy. So because of these three controversies, IgA nephropathy in many continents or many countries and many hospitals is underestimated. Now the next controversy is clinical presentation. There is a gross difference in terms of the clinical presentation of glomerular syndrome according to the age group. And it is still controversial whether the younger patient who present primarily with the IgA vasculitis or intermittent gross hematuria is a same disease which, if missed in earlier age group, is picked up as a chronic kidney disease or nephrotic syndrome stage, or these are two separate entities. So there is a controversy in terms of clinical presentation. In terms of management, in spite of 3-4 decade of research in treatment of IgA nephropathy, which other than conservative treatment of non-specific antiproteinuric drug of ACE inhibitor or receptor blocker, the large trial, multiple from 1997 to 2017, has evolved around the steroid treatment in IgA nephropathy. But in spite of that, as of today, still guidelines suggest that after diagnosis of IgA dominant glomerulonephritis and excluding the secondary cause once we come to primary IgA nephropathy, then still symptomatic treatment, good blood pressure control, protein restriction to a limit, and non-specific ACE inhibitor and receptor blocker is still the standard of care with some specific situation where immunosuppression is used. So with this background, the next 40-45 minutes will be covered some of these aspects with our own experience by different colleagues from the Department of Nephrology and Pathology. And I will request Dr. Bhaumik to cover burden of disease in terms of IgA nephropathy.
Thank you, Professor Agarwal. I think you have given a good introduction to the topic. I will now briefly talk about the magnitude of the disease, which already sir has covered little greater detail. Putting it in a broader perspective, it has always been thought in our country that glomerulonephritis is the commonest cause of chronic kidney disease. Now, subsequently, about 15 years back, we had the Indian CKD registry, and this is the registry data which was published in 2012, about 9 years back. And it was an eye opener in sense, showed that actually diabetes in our country is now the commonest cause of chronic kidney disease. And chronic glomerulonephritis is about 14%, followed by various other conditions. So CGN and IgA, of course, is a part of CGN. We'll come to that. So it's about 14%. What about the world? Now, this is the data from the US, the US renal data system, which has a very excellent database of their patients. And this is the latest annual report of 2021. And in this database of 8 lakh patients, the total prevalent patients of ESRD, and which they've included dialysis as well as transplant, so they're living on renal replacement therapy. And as you can see here, the diabetes is about 40%, hypertension about 25%. Obviously, these are all non-biopsied. And glomerulonephritis is again about 15%. So this is roughly tallying with what we found in the Indian CKD registry as well. So CGN contributes to about 15% of total CKD burden. Now, as already has been said that the Jahrberger in 68 first recognized this condition when IF techniques were introduced in kidney biopsy specimens. It's very important to remember that IgA in the kidney biopsy is sine qua non for the diagnosis of IgA nephropathy. You cannot diagnose IgA nephropathy without doing biopsy as well as immunofluorescence. And it is the most prevalent disease worldwide. And last studies have shown that it is about 2.5 cases per 1 lakh population per year. So this is a rough estimate. But there are two caveats to this statement. First is that in centers with routine active screening for microhematuria will detect more cases, and we'll come to that in a subsequent slide, the countries which have such a condition. And centers which do not have immunofluorescence facilities will miss the diagnosis. So this is what has been happening in our country because very few centers till recently had IF at all. So I mean IgA nephropathy wasn't diagnosed. Sir has already shown this slide, but just a couple of points here that as you can see that it is around 20-30% worldwide is the most prevalent disease. A publication of Sudanese in IJN recently has shown 5.6%, so a little higher. You can see Morocco there, the top left is 12%. But in general, it is thought that it's very uncommon in Africans, less than 5% probably. And if you go to the extreme right, that's Japan, which has a very high incidence. 30-40% of all glomerular disease is IgA nephropathy. In donors, the normal donors, when they have been biopsied, it's as high as 1.6%. So, there is a great difference worldwide, as well as in Southeast Asian countries, it is very high, as you can see here in the next slide. So, it is very common in Asians, moderately prevalent in Europeans, and rare in Africans. So, this sums up the prevalence of IgA nephropathy worldwide. And this heat map, which is quite nice and illustrative, it shows that especially in Europe and Asia, as you go towards the north and go east, the prevalence of IgA nephropathy increases. And that's why the Far East it is very high, as well as in Southeast Asia. And this has been confirmed by population genetic studies as well. What about our country? Uh, First report of IgA nephropathy actually in the literature is of 11 cases from PGI Chandigarh in 1995 in the Journal of Pathology Microbiology. Actually, I think AIIMS, PGI, and CMC were the earliest institutions which had IF. Other institutions did not have IF till recently. So 1995 was the first time when the first report came at Chandigarh. And our own institute, this is a study over 10 years. Biopsies were studied, about more than 3,000 biopsies, which were evaluated. And 73% were primary glomerular disease. About 15% were secondary glomerular disease, that would be lupus mainly. And then 5.3% is chronic tubular interstitial disease, then the vascular diseases and the miscellaneous. So IgA nephropathy accounted for about 10.4% of all glomerular diseases in this very large database. And males to female, it was about 6:1. The data from our institute. What about our country? So CMC Vellore, when they studied more than 5,000 biopsies, reported in 2006, it was about 8.6%. Chennai recently in KI reports about 2,000 biopsies, about 9%, and this is what is expected. JSS Medical College, Mysore, 6.8%. From the east, Kolkata PG, they reported 8.4% in 6 biopsies. The northeast, if you go by the heat map, you would expect to have more number of cases, but this is only data we have, a little discordant. But then from Negrims, Shillong, just 102 biopsies, it was 5.8%. Thank you very much. And now I invite Arun.
A very good afternoon to one and all. So, our understanding about the pathogenesis of IgA nephropathy has been evolving over the last couple of decades. Fundamental to the pathogenesis of IgA nephropathy is the presence of aberrantly galactosylated IgA residues. By that we mean that the number of galactosyl residues which is present in the hinge region of IgA1 is reduced in IgA nephropathy. So this is a classic IgA molecule. In humans, IgA has two subclasses, A1 and A2. The A1 molecule is the predominant one. It is monomeric, predominant in the circulation in about 85%, and tends to have an hinge between the heavy chains. This is something which is missing in A2 and is differentiated from other species also. Apart from this, there are multiple other IgA components like the dimeric, polymeric forms which are quite rare. The secretory one which has a secretory component attached to it. So for all our understanding purposes of IgA nephropathy, we will be focusing only on IgA1 subclass. So what happens is this, in this hinge region, there are normally about 3 to 6 galactosyl residues, the red ones here. What happens here is this, there is a genetic predisposition because of which there is either a deficiency in the galactosyl transferase activity or there is a premature silation which causes the, which inhibits the galactosyl residues to get added on to the hinge, and thereby there is a under galactosylation which happens. So this is the underlying part or the first hit which happens in IgA nephropathy. So what happens is that whenever there is an mucosal infection, there is a stimulation of IgA secretion from the plasma cells, and in these individuals, predisposed individuals, we have more of undergalactosylated IgA being secreted. These molecules are more prone to self-aggregate and they form the polymeric forms. And again, these individuals are more predisposed to have anti-glycan antibodies, which are directed towards these galactose deficient IgA molecules, and thereby they form immune complexes. The formation of the anti-galactose antibody is a second hit. The formation of the immune complex is a third hit. And these immune complexes are not normally cleared from the circulation. They are they get deposited because they are nephritogenic and they initiate injury in the glomeruli. This forms the fourth hit. So this is the multi-hit pathogenesis, which is right now accepted for IgA nephropathy. So once it is deposited in the kidneys, there is activation of the mesangial cells, which that causes release of pro-inflammatory and pro-fibrotic cytokines. There is a podocyte injury, which causes glomerulosclerosis. There is a proximal tubular epithelial cell activation, which causes tubulosclerosis. And right now, complement activation, both the alternate pathway and the lectin pathway, is thought to play an important component in the pathogenesis. And this finally results in progressive renal failure and end-stage renal disease. This is how the pathogenesis of IgA is understood at present. However, we should understand that this is still an incomplete understanding because we still can't explain the trigger for the initial stimulation of production of IgA1, and 2, the variation which is seen between various patients, various patient groups, even with the same histology. This is something which we lack in our understanding even now. So once we understand the pathogenesis, the first part would be to know how to diagnose the disease and monitor the disease. That would be by using of biomarkers. And right now, the only method of diagnosis of IgA nephropathy is a kidney biopsy. And the monitoring or the prognostication is by histological severity index, the MIS scoring, which will be dealt with later. And routine clinical markers like blood pressure, estimated glomerular filtration rate, and proteinuria. So these have been validated across the cohorts all over the world. We should understand that none of this focuses on the pathophysiological process per se. So we would need more markers involved in the pathophysiology so that we can better understand the disease and guide the treatment prognosis. So this is the reason why a number of markers have been developed. This is probably a heat map wherein green denotes that there is lots of evidence, yellow slightly less evidence, whereas red has no evidence. As you can see, the traditional markers are well validated and have been proven across, have been good biomarkers for all other purposes apart from treatment decision and prognostication, whereas the newer markers are yet to be validated. Among the newer markers, what we can see is that the galactose deficient IgA, the galactose deficient IgA C3 ratio, anti-glycan antibodies, complement pathways, and its CD89. These are the markers which have shown some benefit with regard to prognostication, and they are being studied across in various studies across the world. At AIIMS, the first study was from published in PLOS. This was on serum galactose deficient IgA as a potential biomarker for IgA nephropathy. This was published in 2019. In this, the aim of the study was to assess the efficacy of galactose deficient IgA as a biomarker, as well as to correlate it with the severity of the disease. This was a case control study. It had 3 groups. Group 1 of 130 patients of IgA nephropathy, Group 2, 60 patients with non-IgA glomerular disease, and Group 3 of 50 healthy volunteers. All cases of secondary IgA, HSP, and coexisting diseases were otherwise excluded. And the galactose deficient IgA was measured from serum samples which were stored in a biorepository at -80 degrees Celsius. The kit which was used was a solid phase sandwich enzyme immunoassay. So this was the first time a large study was done using a non-lectin based kit, and this is probably one of the first studies where it was been validated across the world, and thereafter multiple studies have proven its use for IgA, for galactose deficient IgA per se. So the levels of galactose deficient IgA was compared in the 3 groups. It was seen that there was a significant difference with regard to the galactose deficient IgA levels. It was significantly high in IgA nephropathy patients. It was 13,870 as against 6,500 in other glomerular diseases and around 7,000 in controls. And when the ROC curves were plotted between the IgA nephropathy patients and healthy controls, for an optimum sensitivity and specificity, the cutoff was 7,980. Whereas with other glomerular diseases, it was 7,747. And with this ROC, it was seen that the sensitivity and specificity was more than 70%. Positive predictive value was more than 80%. The other question would arise is that whether the other glomerular diseases also have this galactose deficient component. So when we saw the individual glomerular diseases like minimal change disease, FSGS, lupus nephritis, or membranous nephropathy, almost the levels in all these diseases were significantly lesser when compared to IgA nephropathy. The next step would be to correlate it with disease severity. So the levels were correlated with the MES scoring system, which is accepted as a histological severity scoring. In this, it was shown that there was no association between the severity in histology and galactose deficient IgA levels. With the surrogate markers of renal disease progression like estimated GFR and urinary PCRs also, galactose deficient IgA levels did not show any positive association. With regard to renal survival, it was seen that those with a high galactose deficient levels, they tend to have a poorer survival. It was 67% at 12 months and 39% at 48 months, as against 80% at 12 months and 63% at 48 months in those with the lower levels. However, this was not statistically significant, but it does show a trend that those with a higher galactose levels, deficient IgA levels, tend to have a faster renal progression. So overall, galactose deficient IgA, it had a positive predictive value to differentiate patients of IgA nephropathy from other diseases, but still it is not a very valid prognostic tool at present from the studies what we could see. Probably it has a utility as a screening tool in those who refuse biopsies or in mild cases because it becomes a non-invasive tool. Probably we'll need more studies, a larger study to come in more. The next thing we'd be seeing would be about vitamin D. Per se, vitamin D has been told to be associated with endothelial dysfunction, vascular calcification, and cardiovascular mortality. It is the deficiency upregulates the RAS system and the NF kappa beta pathway, thereby causing a profibrotic effect. And supplementation, vitamin D supplementation has shown to reduce proteinuria and adapting nephropathy. This was the basis for studying it in IgA nephropathy, and earlier studies, especially from the Chinese cohorts, there are about 6 studies, it had shown that even in IgA nephropathy, vitamin D deficiency is associated with the severity of disease and supplementation does improve outcomes. However, all these data were only from Chinese cohorts, and considering that there are ethnic differences in the disease pattern, the levels of vitamin D deficiency and the response to treatment was expected, that we wanted to see this in our Indian population. This is unpublished data from AIIMS per se. It was done by an intern. In this, it was seen that the prevalence of vitamin D deficiency was around 15%. I'll be going in detail. So this was a retrospective cohort study. It included samples from adult patients with biopsy-proven IgA nephropathy. Again, the samples were obtained from our biorepository, where the samples are collected at the time of the biopsy. The assay was an architect assay, which is a chemiluminescent microparticle immunoassay. This was used to measure the IgA levels. The primary outcome was either renal disease progression as well as remission. And the groups, it was divided based upon whether they had vitamin D deficiency or they were replete. The cutoff was taken as 10 nanogram per ml. So our patients were predominantly in the 3rd and 4th decade of life as expected from Indian patients. The mean serum creatinine was around 1.4 and the mean vitamin D levels was 15.9, and the patients were followed up for a mean of around 21 months. Comparing the patients who were vitamin D deficient and replete, the only significant difference was with regard to the gender and to hyperalbuminemia. Apart from that, none of the clinical factors were different between vitamin D deficient and replete patients. With regard to the histological parameters, the crescentic lesions were more common in the deficient group. None of the other parameters in the MES scoring were significantly different between both the groups. With regard to outcomes, both renal disease progression as well as remission, it was not statistically significant between those with and without vitamin D deficiency. And it was seen that vitamin D deficiency per se is not a significant risk factor for renal survival. And the Kaplan-Meier survival curves for the time to adverse event were plotted. This was also not significantly different between the groups. However, we should remember that this is a retrospective study, has a smaller cohort size, and there is data from a smaller study where calcitriol supplementation had a beneficial effect. So probably a prospective study with vitamin D supplementation may give us a better idea about the role of vitamin D in IgA per se. Last would be genetics. So I've been always saying that in the pathogenesis that those who are predisposed tend to develop antibodies. So how is this predisposition seen is a question. The ethnic differences in both disease prevalence as well as phenotypes and the presence of familial clustering of cases of IgA nephropathy suggests that there may be a genetic basis for the disease. It was seen that nearly 10 to 15% of the first degree relatives of a confirmed IgA patient tend to have some sort of kidney disease, if not IgA nephropathy per se. And it is now considered that an interaction of multiple genes in combination of with environmental factors is probably underlying the pathophysiology of IgA. Multiple genes have been studied across the last decade. ACE, RAS system genes, T cell receptors, interleukin genes, MHC loci, all have been studied. Among this, the D allele of the ACE gene has been shown to be significantly associated in Asian patients. The predict IgA nephropathy cohort did not show the effect of an ACE gene. However, it did show association with glycoprotein and intracellular adhesion molecule genes polymorphism with progression. This was followed by the genome-wide association studies from both the UK glomerulonephritis DNA bank and the Chinese cohorts, where 3 loci in the MHC gene chromosome, defensin chromosome, the presence of APRIL, and the complement pathways, they were supposed to be associated with IgA nephropathy. Studies in Caucasians have shown an association with HLA DQ and DB, whereas in Chinese and Japanese it is with DQAA1 and DRB1. So among all the genetic associations, the MHC loci has been implicated in almost every genome-wide association studies till date. That is why the study has been run in AIIMS to search for the HLA association and the phenotypic variability in North Indian patients. There are no Indian studies in this till date. This was an ambidextrous case control study which included around 172 patients with IgA nephropathy in comparison with 204 patient controls, healthy controls, and all the standard clinical data have been collected. DNA extraction and HLA genotyping have been done from a peripheral blood sampling using standard commercial kit, and the automated analysis was done using the NGS method. And the data is just being analyzed, and the preliminary data, it suggests that the HLA DQB1 is significantly higher in patients when controlled to when compared to controls. Apart from this, HLA certain loci in HLA A, B, C, DRB1, DQB1, they show a trend for a difference between IgA patients and control, but this is not statistically significant. However, none of the genetic markers or were significantly different between rapid and slow progressors. Again, this is still under study and would take a larger data for us to have an idea about this. And till our understanding of the pathophysiology is complete, we'll have to continue our search for biomarkers for both diagnosis and to decide our treatment decisions. Thank you. The next would be clinical profile would be dealt with Professor Mahajan, sir.
Well, thank you, Arun. Thank you, Dr. Bhaumik. So, what I would be talking about is the clinical profile and how we as Indians would have a different clinical profile as a cohort. Well, a lot of stress in today's seminar has been on heterogeneous presentation of IgA nephropathy. We know that prevalence, as Dr. Bhaumik has very beautifully shown, depends a lot upon the geographic and ethnic variation, and so does the clinical profile. We have also come to know that diagnosis and clinical course obviously would depend as to how aggressively you would be screening your population. So countries like Japan, Singapore, to a certain extent China, who have aggressive screening policies, would tend to have more asymptomatic cases being biopsied earlier as compared to the other countries which would not have the similar policy. And how well you conduct, how early you conduct, and what are your indications for kidney biopsy, and obviously, as I highlighted, largely depends upon the availability of immunofluorescence staining. So though we might have ethnic variations, but we also might have other confounding factors which lead to these ethnic variations. So what is the data from the Western countries? Well, 2/3 of the children and young adults would present with the classic synpharyngitic macroscopic hematuria. Older adults would present with a mix and match of proteinuria, microscopic hematuria, or hypertension. 2:1 is the male to female ratio, and nephrotic syndrome per se is an uncommon presentation of IgA nephropathy. As far as the course of disease is concerned, only around 1/3 of the patients would progress on to end-stage kidney disease at the end of 20 years. So this is the data we have from the West. And let's compare it to the Southeast Asian data, predominantly from Japan and China. So the Japanese study, the cohort looked at 702 patients. The median age was 30 years, 42% were male. So as opposed to the Western population, gender equality was there in the Southeast Asian population. The patients had relatively well-preserved GFR, had a proteinuria of less than a gram, and on nearly 5 years of follow-up, around 12% developed end-stage kidney disease. The Chinese cohort of around 1,000 patients again had a mean age of around 34 years. Again, gender equality, 50% females. Again, a preserved GFR, but a higher protein creatinine ratio. And around 15% achieved a combined outcome of more than 50% decline in GFR or end-stage kidney disease on a median follow-up of around 53 months. What are the data from India? Well, the first reported cohort is around a 15-year cohort from CMC Vellore, which looked at a mean age of 30 years. Again, male preponderance with 65% being males. If you note, the GFR or the creatinine clearance reported in this study was much lower. It was 60 as opposed to around 80s. So again, highlighting the late stage in which we pick up the disease. And the other notable difference is higher urinary protein creatinine ratio of around 2.9. As opposed to what we learned from the West, 55% of our patients presented with nephrotic range proteinuria, and not surprisingly, in a short follow-up 16 months, 17% developed end-stage kidney disease. So remarkably different patient and outcome profile as opposed to what we have or what we knew from the Western and the Southeast Asian data. The other study of PGI is a smaller study and maybe basically looked at patients who were only admitted. So it's not a OPD follow-up. It's basically looking at the patients who were admitted, and they looked at the outcome in they look at the presentation in these patients. The mean age was 32. 84%, 81% were males. Patients had much higher serum creatinine, indicating again late stage of the disease. Urine protein creatinine ratio was 2.2 and nephrotic range proteinuria was in 23.1. So in these contexts, a study was conducted in our center, which was published in 2016, where we looked at a 5-year cohort of our patients of around 103 patients. The mean age again was lower, it was 28.8. Again, around 74% were males, and the mean estimated GFR was 76, as opposed to much lower in the PGI and the CMC cohort. But the urine protein creatinine ratio was 3.8, frankly nephrotic range. In fact, 53% of the patients, that is majority of the patients, in fact, presented with edema and nephrotic range proteinuria with or without renal dysfunction. So the patient had come to the nephrology department with nephrotic range proteinuria with and without renal dysfunction and an edematous illness. Only around a quarter had incidentally detected renal dysfunction and urinary abnormalities, which is so very common in the Southeast Asia. And the classic presentation of gross hematuria was in fact uncommon, around 9%. Around 11% patients presented with either a rapidly progressive renal failure or an acute kidney injury. But much more worryingly, 67% of the patient had significant renal disease, that is an estimated GFR of less than 60, of which around 16% had a GFR of less than 30, that is advanced stages of kidney disease. On a median follow-up of 17 months, around 17% patients or 18% patients developed end-stage kidney disease or a 50% decline in renal function. So this busy-looking table actually I have tried to tabulate whatever is major cohorts in the known in the international literature. The first one obviously is the Oxford study cohort, which would be coming on to subsequently. It's a multi-continental cohort. It had a center from South America, North America centers, Europe obviously, and Japan and China. It had 265 patients. The mean age was 30 years. Again, male preponderance. Hypertension was found in 31% patients. Significant proteinuria to the tune of 1.7. Estimated GFR though was well preserved, that was 83. However, on a follow-up of 65 months, 22% developed either a 50% decline in GFR or end-stage kidney disease. There are two important European cohorts from Italy and from France, which have 183 and a pan-European cohort of around 1100 patients. The mean age is slightly higher than what we have from the other centers, from the Oxford cohort and from the Japanese cohort, that is around 38 and 36. Again, predominantly male patients. In this pan-European cohort, a high proportion were hypertensive, again significant proteinuric disease, nephrotic range proteinuria in around 20%, significantly lower GFR, and again on follow-up of between varying from 77 to 56 months, hard renal endpoints in around 20% to 16%. Coming on to the study from China, around 1,000 patients, we know the mean age was 34. There was no male or female preponderance. Significant patients were hypertensive, higher degree of proteinuria with well-preserved GFR, and with a follow-up of around 53 months, as we know, 15.5% developed hard renal endpoint. The Japanese cohort, less proteinuria, well-preserved renal function, but still, in a follow-up of around 5 years, 12% developed end-stage kidney disease. The study, initially from CMC, had around 478 patients, significant proteinuria, much lower GFR at presentation, and again 17.4 end-stage kidney disease in only 27 months. In our cohort, as we have already highlighted, around 17% had a hard renal endpoint in a median follow-up of only 17 months. So, more severe disease probably picked up late and progresses to a deterioration of renal function in a pretty quick time. Another important aspect which Dr. Arun also highlighted once we talk about clinical profile is the pathological correlation, and that is best represented by the MES score. Dr. Geetika would be talking much more detail in that. So it's derived from the Oxford cohort, first published in 2009, and crescents were subsequently added, so it became MES-C in 2016. It basically looks at mesangial hypercellularity, endocapillary hypercellularity, segmental glomerulosclerosis, markers of chronicity, that is tubular atrophy and interstitial fibrosis, and looks at crescent formation. So, and they are appropriately then marked according to their presence or absence of the above signs. So, this is a graph shows the MES score of our population. 80% had M1. So, this is quite a significant number. Mesangial hypercellularity was seen in 80% of our patients. Endocapillary hypercellularity was seen in only 10%. 45% had segmental sclerosis, segmental involvement, while around 41% had chronic changes. Crescents were seen in only around 11%. So, how does our MES score in our cohort compare to the other cohorts? In the original Oxford study, from where the MES score came, again, majority mesangial hypercellularity was seen in 80%, good amount of endocapillary hypercellularity, and segmental sclerosis. In the French cohort and in the European cohort, there was much lower incidence of mesangial hypercellularity, but there was significantly higher number of segmental involvement and some amount of chronicity. And crescents again in 11%. In the Chinese cohort, again lower incidence of mesangial hypercellularity, predominantly segmental lesions, and higher degrees of chronicity. In the Japanese cohort, again segmental lesions were the commonest and significant chronicity. If we look at the data from PGI, the Bellow paper unfortunately came up before the MES score came in, so they didn't report their MES scores. So in the PGI data, which we believe is basically looking at a disease at quite a later end, still 80% had mesangial hypercellularity, and as expected, around 75% had significant chronicity, with around 56% having crescents. That's a very high number, and our data we have already presented. It's predominantly mesangial hypercellularity, followed by segmental lesions and very low incidence of chrysalis. Subsequently, the International IgA Nephropathy Network has come up with a risk prediction tool, which Dr. Samita would be highlighting in much greater detail, which looks at 7 point to look at the overall prognostication of the population. We have reanalyzed our data, and the numbers have now increased to around, and we have compared it to the cohort of the risk prediction tool, both the derivation as well as the validation cohort. And what we have seen is that we are dealing with a relatively younger population, again predominantly males, significantly higher proteinuria, much lower GFRs, and much higher mesangial hypercellularity as compared to any other MESCO or pathological correlation, as opposed to the cohorts which again were multi-continental. Unfortunately, neither the Oxford tool nor the risk prediction tool actually has included any Indian cohort, and it's predominantly from the North American, European, and Japanese and Asian cohorts. So this population is not represented in either the Oxford or the risk prediction tools. And what we see is that these cohorts actually have much higher segmental involvement as opposed to mesangial or endocapillary proliferation. So completely different disease profile as far as the histology and the clinical profile is concerned. So in the end, how do I believe that our IgA profile is different? Our patients predominantly present with pedal edema and nephrotic range proteinuria as the commonest presentation, which in fact is rare in the Western population. Gross hematuria, which is a very common presentation in the West, is rare in our adults. Majority patients have renal dysfunction at present, indicating that we usually pick up the disease late, and this could be because of the referral bias, and we don't have any active screening program. The presence of mesangial hypercellularity in majority, which is quite unique to our population, and lower representation of endocapillary lesions is another hallmark of our cohort. And unfortunately, our patients have a faster decline in renal function, with nearly a quarter having significant hard renal endpoints, even on a very short follow-up period of less than 3 years. Thank you. And I will now invite Dr. Giteka to tell us more about the histopathological profile of.
Dr. Mahajan. Now continue to the pathology. So I'd like to start by just talking about histological diagnosis, what we really do for patients who are biopsied. We would run them through a standard kidney biopsy protocol. We look at 2-micron thick sections, our standard 4 special stains, and these are the kind of pictures which are the most common histological patterns of IgA nephropathy. So as we have alluded to the MES-C scoring, so mesangial hypercellularity is the most common sort of presentation, and there are very strict criteria according to Oxford. We need 3-micron thick sections, PES, stain slight, stay away from the hilum, and this is how we do the counting. So if you have more than 3 cells in a mesangial area, we would consider it as M1. If more than 50% of glomeruli show it. This is another situation where you can get endocapillary hypercellularity, and this is really what it looks like. And as we have seen in terms of our clinical profile, most of our patients are very advanced, and therefore we can see significant interstitial fibrosis and tubular atrophy, like you can see here. But the hallmark of IgA nephropathy is its very wide degree of histological variability. So we can see patients who have minimal change morphology to even a very diffuse proliferative and crescentic GN. Immunofluorescence remains the mainstay of diagnosis. We have a very now well standardized IF protocol where we would run a battery of stains which look like this. And if we see mesangial granular confluence staining for IgA, usually codominant with C3, kappa and lambda, a lot of patients may show lambda accentuation, we would render a diagnosis of IgA nephropathy. Again, from pathology point of view, we know that not all glomeruli stain, and there can be again wide variability in IF patterns from glomerulus to glomerulus. And the third modality that we subject all our kidney biopsies to is transmission electron microscopy. And for our IgA nephropathy patients, we would be looking for electron dense deposits in the mesangium, which would correspond to the immunofluorescence positivity. And we also look at the health of the podocytes, which correlates very well with the extent of proteinuria. And as mentioned, clinically, a lot of patients of ours do have significant proteinuria, and we would see unhealthy, effaced podocytes. So this is our standard protocol workup for IgA nephropathy. We would also provide MESC scoring, which is a histology-based prognostication, which has been described in detail as the M is mesangial hypercellularity, endocapillary, segmental sclerosis, the IFTA, and then the presence or absence of crescents. And all of these have significant clinical correlates. Now, beyond what we are doing routinely for our patients, we have now a much better understanding of the pathogenesis, as Dr. Arun had explained to us that the type of IgA which deposits in IgA nephropathy is different from usual systemic IgA. It is galactose deficient. This galactose deficient IgA is a physiological IgA which is secreted by the plasma cells in the mucosa, but it's not supposed to enter the systemic circulation. It's supposed to stay there in the mucosa, which doesn't happen in these patients. The hypothesis is that there is plasma bone marrow homing of these plasma cells. So they go to a wrong location, and now you have excessive mucosal type IgA, which is hitting the systemic circulation, and it goes for the kidneys. So can we demonstrate this? We can. Just as KM55 in the serum, in a very nice study which was published in PLOS One from our group, showed that serum KM55 levels were much higher in patients of IgA, but you must note that they were not absent in other patients. So patients of lupus or minimal change still had a little bit of that physiological mucosal type IgA in their systemic circulation. So we tried to do this again in tissue demonstration of KM55. We picked up a host of diseases, which included the regular IgA nephropathy and other diseases as well. And what did we find? We found that we could do a tissue-based demonstration of this same galactose deficient IgA. You can see a classic patient here. This is the IgA mesangial granular. This is the KM55, and co-localization was demonstrated here with this yellow staining. So it co-localized very well. We put in a protocol which we had standardized in the laboratory and published in 2016, which is a paraffin immunofluorescence protocol, which worked very well for this stain. And it's a very new stain in the field. Very few labs have actually standardized it. So from our experience and the collective experience in literature of 107 cases, if we put them all together, we now know that it's a very consistent marker for IgA nephropathy in renal biopsies. And as experience was gained in the renal pathology laboratory, we understood how to interpret it. For example, a patient of minimal change disease, which doesn't really show too much staining, maybe a few dots here and there. In a patient of FSGS, just like you can get some non-specific adsorption of IgA, a similar non-specific adsorption pattern for KM55 can be seen, again highlighting the fact that this is a physiological form of IgA, just too much and in the wrong location. This was a patient of Alport syndrome, which we had actually thought was a patient of IgA nephropathy, but as we came to the EM, you can see classic AS changes, Alport syndrome changes, and a non-specific KM55 staining pattern. So we now recognize confluent mesangial granular positivity is a requirement to interpret the stain, which has now resulted in us really picking up interesting cases and reporting it in literature. This was a pediatric patient of IgA with atypical anti-GBM disease, and you see a complicated histology, an IgA on immunofluorescence, a beautiful KM55. So we have GAL deficient IgA there. Along with that, this patient had linear IgG staining in the capillary walls, which was IgG1 dominant. So we had two diseases, and KM55 really helps us. So in highlighting and confirming IgA nephropathy, this stain is working very well in the lab. With a better understanding of pathogenesis, we then came to a cohort of patients which was secondary IgA nephropathy. And the question that we said, well, is it real? Is it really a different disease, primary and secondary IgA? So before I go to classic secondary, if we look at HSP, which we understand is a systemic form of disease or IgA vasculitis, what we found is that they also stain very strongly for GAL deficient IgA. So what this means is that IgA nephropathy and HSP share the same pathogenesis of deposition of GAL deficient IgA, only difference being that the systemic manifestations of a small vessel vasculitis in an HSP, and this has been proven in parallel studies just in the last few years. Now, if we come to secondary IgA nephropathy, for the pathologist, this also becomes important because These diseases, there's a host of diseases which get associated with IgA nephropathy, various comorbidities, no consistent definition in literature, and we have no histological features to differentiate primary versus secondary IgA nephropathy. And you can see this whole list of diseases which we learn as we go through our regular texts. So what we found when we started staining our patients of so-called secondary is that they also stain brilliantly for KM55. So what does this mean? This means that these so-called secondary IgA and primary IgA have the same underlying pathogenesis of systemic overproduction of a mucosal type IgA, which may be exacerbated by the secondary causes with which it is associated. For example, in a Sjogren syndrome, you do have mucosal plasma cell rich infiltrates, which may be the trigger in a patient who is genetically predisposed to IgA nephropathy. In other cases, there may be no direct effect of the perceived secondary cause, and you may actually just have two diseases happening at the same time in the patient. This again, as we started staining and our data started coming out in parallel, we started seeing very recent data from 2020 care reports, for example, of similar experience from other labs staining with this antibody. Now, the CLD-related IgA, I just want to spend a minute on because it's considered to be the most common secondary cause. We consider patients of chronic liver disease to be very predisposed to IgA nephropathy. On histology, they do have subtle histological differences. They tend to be more proliferative. You can get endocapillary and membranoproliferative patterns. You may get crescents. But if you look at the staining pattern, again, we see that there is definitely galactose deficient IgA there. And we put up a cohort with collaboration with another center in Delhi, 15 cases, all of which stained for KM55, even though they had subtle histological differences on the biopsy. Now, why would patients of CLD also show a similar look as IgA nephropathy? There are factors which would exacerbate this deposition. There are defective intestinal barriers in these patients. There is portosystemic shunting, helping everything to enter the systemic circulation. Also, we must remember that the liver is a site at which IgA is excreted, and you would have cleared. So you would have reduced clearance of Gd-IgA1, one because of its galactose deficient nature, and second because you have loss of hepatocytes in CLD. So to conclude, secondary IgA nephropathy now, as we understand the disease better, basically shares the same pathogenesis as primary IgA nephropathy, along with maybe additional pathogenetic factors which may precipitate the disease. And it would be really interesting if the same HLA studies like Dr. Arun had shown, which is still unpublished, if we could widen our cohort and look at these patients as well to see if they have the same genetic background as IgA. Now, the next thing, as we understand the disease better, is confounding histology. So as we can see, not everything with IgA is IgA nephropathy, and this can be a major problem when we're coming to diagnosis. But what we saw is that when we stain our lupus nephritis, which we know can show full house with IgA, these are negative for KM55. This is a patient of a suspected cryoglobulinemia. You can see hyaline thrombi, very strongly positive for IgA, negative for KM55, large electron dense deposits on electron microscopy. So we could conclude that systemic IgA containing glomerular diseases, SLE is of course the prime example, these are negative for KM55. So we could now, for example, diagnose a patient of IgA in a case of SLE very confidently. So those situations do arise. In terms of other confounding histologies, membranoproliferative pattern of glomerular injury is a major confounding histology. Rarely patients of IgA nephropathy may show that pattern, although it's not very common. And that results in a lot of differential diagnosis when IgA is there. And the second pattern which can cause confusion is an endocapillary proliferative or crescentic pattern, where the main differential diagnosis would be an IgA dominant infection-related GN. So what we found was that when we had a membranoproliferative pattern of injury, as you can see here, where you have a lot of capillary wall reduplication, this is not a classic IgA pattern of injury at all, but it stained very strongly for IgA. Diagnosis rendered usually would have just been an immune complex mediated MPGN, but since we could prove that this is GAL deficient IgA, our diagnosis changed to IgA nephropathy. This, of course, is much more useful information to the nephrologist when we get back to them rather than just saying IC-MPGN. This is another patient who had endocapillary proliferative and a more crescentic sort of pattern of glomerular injury, where the differential diagnosis came out to would be IgA dominant IRGN. A lot of IgA there, but again, we could prove that it's GAL deficient. We could prove the presence of deposits. So this was just a more proliferative pattern looking IgA nephropathy. So we are much clearer now in the way that we look at these cases. So with a better understanding of pathogenesis, KM55 is proving to be a very useful stain. We are able to prove presence of galactose deficient IgA and therefore mucosal origin as opposed to systemic origin IgA as a driver of the glomerular pathology. We understand primary and secondary IgA nephropathy much better, and we are able to resolve differential diagnosis when we have IgA on the biopsy. I'd like to just thank the renal pathology team, Dr. Adarsh, Dr. Varun, and Dr. Rahul, whose work I've presented, and the staff. Dr. Sharma?
So coming to the prognostication and management of IgA nephropathy, basically it's classified into supportive treatment and immunosuppression. The goal of treatment is to reduce proteinuria less than 1 gram per day with a stable kidney function, with a complete remission being defined as a proteinuria of less than 0.5 gram per day. The kidney disease improving global outcomes just last year came up with the updated guidelines based on whatever recent research, which has to some extent changed how we look at IgA. The basic approach to treatment is that if you have an IgA dominant glomerulonephritis, you depend on the pathologist and the clinical findings to rule out IgA vasculitis and IgA dominant infection related GN, because they have a slightly different approach to treatment. Rule out secondary causes of IgA because you would be selective and rather wary about using immunosuppression in these patients. Then you stratify these patients and quantify the risk progression based on a prediction tool, which Dr. Mahajan just discussed with you earlier. And this is important only for counseling the patients about how frequent their follow-up should be, what is the risk of end-stage kidney disease in the long term, and not for treatment. Then you start supportive treatment in all the patients, and only if that does not work, you go for immunosuppressive treatment. So the International IgA Nephropathy Prediction Tool was based on 3,000 plus patients, Europeans, Chinese, Japanese, no South Asians. They predicted the 5-year risk of 50% decline in estimated GFR or the risk of end-stage kidney failure. And they developed two models. One had clinical and histological variables, age, eGFR, the mean arterial pressure, the proteinuria at biopsy, whether the patient had any history of immunosuppression use and RAS blockade before or at the time of biopsy, and the MEST score. The MEST score was only limited to MEST, crescents were not included. And the second model used the same parameters but added race as an additional characteristic, which was white, Japanese, or Chinese, or other, which meant no racial or ethnic characteristics provided. They classify the patients into using these parameters. They developed a risk score and they classified the patients into low, intermediate, and higher and highest risk based on the observed progression of kidney disease over 5 years. So we looked at this tool in Indian patients, especially since it has the original cohort did not have any South Asians. And this was in 316 patients. And if you look, both the models separated the risk groups very well in our cohort. So a patient who is low risk has definitely a better survival than an intermediate risk, the higher risk, and the highest risk group. And this was true for both the models. But then if you look at the subsequent progression, it varies completely. So this is the original model. And if you see there is a very good concordance in the observed and the predicted risk. Well, in our model, in our patients, both the models, the risk was significantly higher than what was predicted by both the formulae. And this was true for every risk group, though it was more specific for the intermediate, higher, and highest. So if you see, this is the original model. What is observed and what is predicted are very similar in all the 4 groups. In our model, there is a significant divergence, and this is true for all the 4 risk groups, but more so for the intermediate, the higher, and the highest groups. And this is true for both models. So it doesn't really work very well. And this is the overall how it works. This is what is observed in our patients and what was predicted in our patients by the validation tool. So currently, we should not be using this tool in our patients for prognostication. And this actually shows that we actually do have severe disease. It used to be considered that if mild disease is there, we just diagnose them late and that is why see more severe. But even the milder patients who are Indians, they progress faster than a milder patient with other ethnicity. Coming to supportive treatment, it should be given for 3 to 6 months. ACE inhibitor or ARBs are the mainstay of treatment, of course, and should be given to all patients if they have proteinuria more than 0.5 gram, irrespective of the hypertension level. Strict blood pressure control is important. But there has always been this controversy about how much to give, how long to give, and the criticism of earlier trials on immunosuppression was that they started immunosuppression very early without giving a good dose of ACE inhibitors or giving it for a long enough time. So we established the primary IgA nephropathy prospective cohort in 2018. It included patients who had an EGFR of more than 30 and a proteinuria of more than 1 gram who had never received ACE inhibitors or immunosuppression in the past. They were given a standardized treatment, either ramipril or losartan if intolerant to ramipril, with a good blood pressure control and dietary counseling. And remission was looked for after 6 months. If you see a 3 months, 36% patients had remission, of which only 6.3% had a complete remission, which increased to more than 50% at 6 months, and 31% of them had complete remission. So if you wait and watch with close monitoring, you can get away with just giving supportive treatment, but it has to be very closely monitored. 15% patients required losartan because they could not tolerate ramipril, mainly because of cough. 17% discontinued ACE inhibitors, mainly because of deterioration of renal function, mostly in patients who had more severe disease at baseline, and some were in elderly patients. Overall, otherwise well tolerated. The best thing was almost 93% of our patients received at least 50% of the maximal dose, and 60% received 100% of the dose. The blood pressure control was similar in both the groups, whether they achieved remission or they did not. So we cannot say the difference was because of control in hypertension, but it was mainly because of the RAS blockade. We did not use any other supportive treatment other than what I showed earlier. We published this cohort late last year, and basically we found that the remission rates are better with 6-month therapy. So waiting and watching is a good policy. And those who fail to achieve remission are those who have severe disease clinically, low GFR, low serum albumin levels. Surprisingly, if you're hyperuricemic, then there is a lower chances of response with ACE inhibitors. They had a higher proteinuria, but it was non-significant, probably because it was a small cohort. They had more chronicity on the biopsy, but they also had significantly higher endocapillary hypercellularity. And surprisingly, this cohort did have patients with crescents, C1 crescents, and that did not make a difference to the outcome or response to ACE inhibitors. Steroids have been routinely used for immunosuppression use, but the Stop IgA came in 2015 and questioned it. It was a European cohort which showed that though it decreases proteinuria, it does not really improve the renal survival and has significant adverse effects. They gave a 10-year follow-up in 2020, which also showed no difference between immunosuppression. But again, this was a European cohort. Subsequently, mainly the testing has suggested that immunosuppression may be useful. The standard dose testing was stopped in 2017 because of serious adverse events, with deaths reported due to infections. They had mainly a Chinese population and had some patients who had low EGFR. The low dose testing, which was presented, so the combined data of 500 patients with low dose and standard dose was presented last year in ASN, and they said that it works better compared to placebo, supportive treatment. 47% reduction in risk of major kidney events, and adverse events were only seen in the high dose cohort. The low dose cohort had a lower incidence of adverse events. Based on this, KDIGO said that if the patient has persistent proteinuria after 3 months of therapy, should be given steroids, should be avoided in patients who have a GFR less than 30, because even testing had only 26 such patients. Neither MEST nor the IgA prediction tool should be used to decide on treatment. So it should be very individualized. We looked at steroids in our patients a few years back. 94 patients, heavily proteinuric with 5.2 gram proteinuria, creatinine of around 1.4, relatively preserved GFRs. So 55% patients showed no response. So half of the patients do respond to steroids, and patients who achieved even partial remission did significantly better as per renal survival compared to those who had no response. The catch is significant adverse effects. 20% patients had serious adverse events. 17 had infection. 2 had diabetes. 1 had AVN in the femoral head. And 1 patient died due to nocardiosis. Other therapies, all other immunosuppression which have been widely used for FSGS and membranous don't really haven't really shown very good results in IgA, except for MMF, which has shown a benefit in Chinese patients. Surprisingly, not in non-Chinese, but the non-Chinese studies are Europeans. We don't have Indian data. We do use MMF in our service, but I just don't have the data to show right now. Hydroxychloroquine, which is routinely used in lupus, is now put in the guidelines that it should be considered in Chinese patients before you go ahead and give immunosuppression. Based on this RCT, again, only Chinese data. We started using hydroxychloroquine before 2 years. This is a small case series, 37 patients with relatively preserved GFRs with more than a gram of proteinuria. All had received supportive treatment for at least 6 months. We gave a weight modified EGFR modified HCQ dose. It worked quite well. More than 50% responded to HCQS, and none of them progressed in the 6-month follow up. Of course, patients who had higher proteinuria did not do so well. And the biggest issue was 8 patients relapsed after stopping HCQS at 6 months. So we need to give a longer therapy, needs to be studied further. There are a lot of newer therapies. The most interesting ones being in advanced phase 3 trials are the gut associated, the gut absorbing limited steroid, Nefecon, which is expected to have less side effects and equal efficacy as oral steroids, and the complement inhibitors, which are all in phase 3 trials. Dapagliflozin is, of course, the flavor of the season. So, the initial DAPA-CKD trial had a large number of IgA patients, which suggested that there may be a benefit, but we need to remember this study was not designed for IgA, so we need more data before integrating it into supportive treatment. But it's a well-tolerated drug, reasonably so, maybe a good addition to the supportive armamentarium. To summarize, Indian patients do have a severe disease phenotype. They have more mesangial hypercellularity with significant chronicity on biopsy. We should not be using the prediction tool. Maybe we need a correction factor, but at present it underestimates the prognosis. We do not have a validated biomarker currently, and supportive treatment, we should be using it more effectively. Effective dose, close follow-up before jumping to immunosuppression because it has significant side effects. A big thanks to pathology because any IgA work starts with a biopsy. So Dr. Gitika, Dr. Adarsh, and of course Professor Dinda is not here today. And Department of Transplant Immunology, Dr. Uma Kanga, who helped us with the HLA work. Department of Lab Medicine, who helped us with the GAL deficient IgA work. All the senior residents of our department in the past and who are currently working, because you cannot run a cohort like this without their help. I know I trouble you guys a lot, but thanks a lot for the help. And of course, all the patients of IgA nephropathy, it is their regular follow-up which makes this work possible. Thank you. Professor Bhomik will now be giving a sum up.
Thank you, Shomita. My thanks to all the speakers for having given a flavor at least of a very common glomerular disease. Unfortunately, has a very severe presentation in our country, as has been very nicely illustrated. It was thought to be very benign when it was first diagnosed initially in the 70s, 80s, but now it has been found to have a very bad presentation and severity in our country. As of now, there is no validated biomarker. We don't have a biomarker. It has to be a biopsy. There is no appropriate or specific treatment. The treatment is supportive and maybe steroids. The Japanese, they do tonsillectomy in all their patients. It has not been found to be helpful in others. MMF in Chinese, as Shomita has shown, and we just have steroids. So, is there any questions? I think. Yes, Dr. Sino.
Thank you very much for an excellent presentation from the Department of Nephrology. Just two simple questions which probably may sound very common or ordinary for pathologists. Number one is what happens to the pathological changes in patients who respond to treatment who do not respond to the pathological changes in kidneys yes. And the second question is, see, we are only looking at giving treatment to a target which has been affected. So what progress has been made to reduce the secretion of the galactose deficient IgA into the serum? Has any work been done in that direction?
Yeah, so I think both questions are quite valid. Coming to the first question, of course, that would require a repeat biopsy, isn't it?
Are there any
Not
studies?
routinely being done. No, routinely repeat biopsies are not being done. It's only in lupus nephritis that recently, there are many groups which are suggesting and doing repeat biopsies. But Dr. Gitika, I think, will be able to tell better if there are any changes, maybe in animals or others. But in humans, at least, we do not do repeat biopsies in majority of our cases.
Absolutely. There is no data right now on repeat biopsies because it never gets clinically indicated. Once the diagnostic biopsy is done, unless there is a diagnostic issue where they're not sure about the diagnosis, get repeat data in which there are follow-up repeat biopsies, clinical follow-up as we speak.
Yeah, and the IgA prediction tools, etc. Everything is based on the first and only biopsy. You just predict what might happen. It doesn't work out in India, as Shomit has shown.
Also, in terms of targeting the GAL deficient IgA, again, there is no specific therapy out there which is designed to go after that IgA because, like we've mentioned, that it is a physiological mucosa type IgA in our body. So I wanted to just put out a very interesting point here, which comes out in very old papers, that the reason why IgA happens more in the East Asian populations is because it developed as an evolutionary mechanism to combat parasitic infestations. It was the gut parasitic infestation, which much more common in the East, which resulted in that evolutionary, the HLA, and then that became a problem for us because we have too much of the mucosal type IgA, which then hits.
There is no African data, but if that is the case, then you should see it more in Africa.
Yeah.
No, but I'm really surprised that no work is being done to reduce the amount of the galactose deficient IgA coming in. So are there, yeah, like suppose, can we identify people who are at risk to develop IgA nephropathy and take some preventive steps to prevent the secretion of IgA into the, is it possible to identify the cohort of
Biomarkers,
patients
isn't
who
it?
are at risk and like strike at the source rather than look at the target? Thank you. Thank you.
Thank you very much. Thank you.